study buddy. This is your local 4th year med student Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 1 version of the case, where the information is geared towards that exam in particular. Check out the Step 2 version of this case if you're prepping for that instead. And lastly, I'm not a real doctor yet, so all the info and sources are taken from real doctors and their guidelines listed in the description. And a disclosure, all of this information is for the purpose of education, and none of this should be taken as medical advice. So for our first case, it's going to be a 68-year-old man with shortness of breath. Did he swallow a Lego, get stung by a bee, or try to ask out his crush? I don't know. Let's find out. So a little bit more about his history. His shortness of breath has been worsening for the past 4 days, and now he can't sleep. Exertion or walking makes it worse, and albuterol kind of helps. He's had a chronic cough for about 4 years now, for most of the year, and he's coughing up white or yellow sputum, but nothing red. He's been wheezing for about 4 days, and he also feels some chest tightness. He's been complying with medication, he doesn't have any oxygen at home, he doesn't have any travel history, and he's also up to date with vaccines. A review of symptoms is significant for some tiredness or fatigue, but no fever, chills, or weight loss. He doesn't have any chest pain or palpitations. He is coughing, he's wheezing, he doesn't have any nausea or vomiting, and he doesn't have any swelling of his extremities. So let's translate a little bit of his symptoms into medical terms. First, let's talk about his cough. So his productive cough has been going on for quite a while, more than 3 months for over 2 years, and this is the definition of chronic bronchitis. It's usually caused by cigarette smoke, but basically could be caused by inhaled irritants to the lungs like smog. So let's finish up with the rest of his history. He has a smoking history of 1 pack per day for 40 years. He drinks 3 beers a week, and he doesn't do any recreational drugs. For medications, he takes amlodipine and albuterol. And on physical exam, you hear bilateral wheezing and crackles. He also uses some accessory or intercostal muscles to breathe, and his lungs are hyperresonant to percussion. So let's break down his lung sounds for a second. The first thing you hear are crackles, and these kind of sound like Rice Krispies in milk, or like Velcro shoes being ripped off. And this is a popping sound that's mostly on inspiration. And the sounds can depend on the size of the airway. For instance, if you have coarser crackles, this indicates larger airways are affected. And if you have finer crackles, this indicates smaller airways are affected. But essentially, it's mucus or fluid that closes off these airways, and when you breathe in, these airways snap open, making that popping sound. Another lung sound we hear is wheezing, and this is a musical, high-pitched sound on expiration, heard with a stethoscope. And often patients or families will say that they're wheezing, but you kind of have to suss out whether it's a true wheeze, because you really only be able to hear a wheeze with a stethoscope. This is caused by narrow, small airways, otherwise known as the bronchioles. And this is an indicator of a low peak expiratory flow rate, meaning the airways are so swollen that you need a lot of pressure to breathe out, and that makes that whistling, high-pitched sound. You'd be able to see this on a low forced expiratory volume, or FEV1, on pulmonary function tests. And something that's sort of like wheezes, but lower in pitch, are rhonchi. And these are made from constricted large airways in expiration, instead of wheezing, which was small airways. And lastly, there's stridor, which we don't hear in this patient, but this is a high-pitched inspiratory sound made from the obstruction of the larynx, which is an upper airway obstruction. So let's do a little bit of diagnostics. For workup, he got a chest x-ray, which showed lung hyperinflation, increased AP anterior-posterior diameter, and a flattened diaphragm. On pulmonary function tests, he had a forced expiratory volume in 1 second, or FEV1, of 50% of predicted, a forced vital capacity, or FVC, 80%, and an FEV1 over FVC ratio of 63%. So let's talk a little bit more about the diagnosis. He evidently did not swallow a Lego, but he does seem to have COPD, otherwise known as chronic obstructive pulmonary disease. And how do we know this? Well, first, his symptoms line up. Chronic bronchitis with a productive cough lines up with an acute on chronic exacerbation of COPD. On exam, he has wheezing and crackles, which is typical. For history, he has the risk factors of a 40-pack year smoking history, and his diagnostic testing shows a obstructive pattern of pulmonary function testing with a decreased FEV1 to FVC ratio. Some other differentials to keep in mind include pneumonia, maybe, but He doesn't have a fever. He also doesn't have blood or green sputum, so I don't think that's it. So he could have a pulmonary embolism, but this onset was more gradual rather than sudden. He doesn't have any pleuritic chest pain, and he doesn't have any travel history, immobilization risk, recent surgeries, or cancers. He also could have an arrhythmia or a heart attack, and this would be ruled out by an EKG probably done at the ED or the office if they have it, but he didn't feel any palpitations. So I think this case is most likely a COPD exacerbation. So let's talk a little bit more about that. COPD is made up of two main flavors, one of them being chronic bronchitis and the other one being emphysema. So chronic bronchitis is indicated by longer than or equal to 3 months of productive cough for over 2 years. And this is caused by irritants that lead to hypertrophy and hyperplasia in the mucus glands in the bronchi. And how much is too much hypertrophy and hyperplasia? For this, we use the Reed index. And the Reed index measures the thickness of the glands in the airway wall, and a normal ratio of gland to wall is less than 0.4. And on histology, the glands kind of look like eclairs, but when you cut into a histology slide, they look like donuts instead. And instead of squishing out Chantilly cream, they squish out mucus instead. Delicious. And a higher ratio means that the irritants were present for too often, for too long, and caused more glands to pop up. The other flavor is emphysema, and this can also be caused by smoking, but in this case, the inflammation causes a permanent enlargement of air spaces. And it's kind of like the rubber band that's just doing the most, closing the bag of cereal forgotten in the back of the pantry. But after a long time of being stretched out, it doesn't spring back the way that it used to. And like a rubber band, these air spaces also lose their recoil. And because the damage also impacts alveoli, where gas diffusion occurs, they can also have a low DLCO, or DELCO. This stands for diffusing capacity for carbon monoxide, meaning that air exchange is not as efficient in getting oxygen in and CO2 out. Smoking tends to cause a centroacinar pattern, where the damage is concentrated in the respiratory bronchioles and in the upper lungs, because this is where the air you breathe in hits first. And the other common cause for emphysema is alpha-1 antitrypsin deficiency, which causes a pan-acinar emphysema pattern because the deficiency in the enzyme is everywhere in the lung. And this obstructive pattern explains his chest x-ray finding of hyperinflation because of something called air trapping. And this is where you're not breathing out the air you just inhaled, and new air with oxygen in it doesn't hit the alveoli where you can exchange CO2. Air trapping is a result of breath stacking, where you inhale more than you exhale, so you end up keeping some air in your lungs every time, and so you're just building up air in your lungs. And this causes the hyperresonance on lung percussion. The histology of emphysema just looks really spacious, and destroyed walls of alveoli is no longer nice and circular, just wisps of tissue. And let's go over some of these pulmonary function test findings. So if you look at the volume curve for pulmonary function testing, it looks like the world's scariest roller coaster. But the mechanism doesn't have to be scary. So the first thing they measure is your tidal volume, or the normal air that you breathe in and out without even thinking. And then if you take the largest breath in you can, any air on top of your normal breathing is the inspiratory reserve volume. And then once you have all the air you can in your lungs and you breathe out everything that you can, the air that you breathe out extra from your normal breathing is the expiratory reserve volume. And the entire volume total that you breathe out, that is your vital capacity, or how much your lungs can move with the maximum amount of inhale and exhale. There's a little bit of air still left in your lungs because when you breathe out, your lungs don't completely collapse. And this minimum amount of air left just to inflate the alveoli is called the residual volume. And the vital capacity plus the residual volume gives you your total lung capacity, or how much air your lungs can hold in general. So when we look at the forced expiratory volume in 1 second, or the FEV1, this is how much air you can exhale in 1 second. For obstructive lung diseases, because there is an obstruction in breathing out air, your FEV1, or how much air you can exhale quickly, is decreased. And on a flow volume curve, you get this real steep decline in your exhale. But your forced vital capacity, or FVC, is normal because your lungs can hold the equal amount of air as if you didn't have obstructive lung diseases. And in some cases, with emphysema and air trapping, you can even have an increased FVC. And some of the complications of COPD include spontaneous pneumothorax, where there is a weak wall alveoli bleb that pops like a balloon, and so then you end up having air in your pleural space between the visceral and the parietal pleura. And another complication is pulmonary hypertension. And this happens when the lungs vasoconstrict, when the alveoli are not well ventilated. And so if you are chronically not ventilating your alveoli because of obstructive lung diseases and damaged alveoli, then your pulmonary arteries are going to vasoconstrict, leading to an increased pulmonary artery pressure. And all of this makes the right heart work a lot harder than it's used to, and can cause right heart failure and fluid overload. An isolated right heart failure from COPD is called cor pulmonale. So we found out that he has COPD, but what do we do about it? Well, there's a couple of categories of treatment options for chronic COPD. One of them being short-acting bronchodilators. This is usually first line, and we have beta-2 agonists like albuterol and muscarinic antagonists like ipratropium. Our second main category includes long-acting bronchodilators, and this includes our beta-2 agonists again like salmeterol and our muscarinic antagonists like tiotropium. And our last category includes inhaled corticosteroids like fluticasone. The idea of these inhaled corticosteroids is to reduce chronic inflammation to slow permanent changes like fibrosis, and these aren't to be used alone. The TORCH trial in 2007 looked at over 6,000 patients with COPD and found that the combination of inhaled corticosteroids and long-acting beta-2 agonist salmeterol reduced exacerbations and probability of death in 3 years compared to inhaled corticosteroids alone. So do you remember in elementary school field trips where you had to hold hands with your bus buddy so that when you eventually do get lost because you're 6 and have the same attention span as your age in seconds, at least you have some entertainment? Well, the inhaled corticosteroids has to have a bus buddy too. And this is in the form of salmeterol and fluticasone, or budesonide and formoterol. And after you use it, make sure you rinse and use a spacer. This decreases the risk of oral thrush, which is the growth of candida, a white yeast, in your mouth that looks like spots that you can scrape off. And our last section is curiosities and conundrums. And this episode's rabbit hole is pulmonary function tests. And I don't know if you looked up the equipment they use for pulmonary function tests, but I think this contraption is really cool. So basically they go into this telephone booth-like thing with a tube sticking out of it, and that's where their mouth goes. And first they plug up their nose to prevent some unmeasured air from going in and out. And they measure your normal breathing, or the tidal volume, and they make you inhale as fast as possible and exhale as fast as possible for 6 seconds, and repeat that at least 3 times. And I don't know if you've tried to exhale for 6 seconds, but I ran out of breath by like 2.5 seconds, and if I had to do that 3 times, I would probably pass out in that telephone booth. So that wraps up the case for now. Feel free to check out other cases on the podcast in the meantime. Drop us a comment to let us know how we're doing, and next time you pass by a friend who's always just a tad too stressed, tell them, "You take my breath away," and then ask for your albuterol inhaler back. All right, see you in the next one.